Okay, so we're just going to be looking at the ACE wound assessment template. When you go into your patient, this is the screen that you'll be shown. If you scroll down right to the bottom, there's a folder called specialist templates. Sometimes this folder will be shut if you've never used these templates before, so you just need to open it with the arrow there, and then look down for your star, which will say ACE wound assessment template. So if you click on that and then click to your star, it will then open the template for you. So the first page is just a guidance page for the information of the template that's been made. The next tab is the holistic assessment view. So this will show you if any services have done a holistic assessment, and that information will be shown in this tab. Just gives you information about the patient and a way of you to know if a holistic assessment has previously been done for this patient. Your next tab is the consent and history page. So the first box you come to is the consent status. This is about how the patient is consenting to the treatment that you're being given, including wound photography. There are a number of presets here, but you can also free text into this box. So if the patient has capacity and consents to treatment and wound photography, then obviously that can just be clicked and press OK, and that will put that in there. If you did then need to write further information about that or take bits out, so the patient may consent to treatment, however does not want wound photography taken, you can just write that in. If the patient doesn't have capacity, then obviously they're unable to consent to the treatment. If you're doubting capacity for any reason, then a mental capacity assessment form does need to be completed as the evidence of why you feel this and what the outcome was. So the form for that is just below this box just here. So when you click that, that will open as a Word document, and it just guides you through what to do to assess the patient and then how to make contact with the patient's next of kin. Just remember, if you do find pressure damage, duty of candour is about informing the patient or the relevant person of that incident. So it's going to be important that if the patient is deemed to not have capacity, you've identified on there who their next of kin or power of attorney in relation to medical health is, so that the appropriate person can be informed. Next box you come to is the patient's past medical history. So this is just including any information you gather in your assessment, just remembering any medical conditions that may have a detrimental effect on wound healing, and sort of making links to that within that. It's also important to look at that patient's comorbidities and link that to the patient's risk of pressure damage. So that could be identified in this box as to why you feel the patient may need extra pressure relieving equipment or extra turning advice given because they've got quite a complex medical history, and it's just important to acknowledge that in the patient's record. The next box is about medications. So this will be reporting any medication that the patient is currently taking. This includes any antibiotics the patient might have been on. So if it was a post-op wound and the patient was discharged on antibiotics, how long was that planned to continue for? Because it allows for people to then look at it and review it. You've then got a list of observations. This is good for having baseline obs on your first assessment, so that if we were ever querying that the patient had sepsis or any other concerning conditions and they're deteriorating in general, you would then have these baseline observations from your first assessment to be able to look at. So generally this page only needs to be done on the first assessment, unless of course there's any changes. You'd obviously have to fill in your consent box each time because you need to document that for your intervention that patient is consenting. But for the past medical history and medications and general baseline obs, that would be part of the first assessment that you would be doing. Okay, then we start our skin bundle. So really this is looking at the patient's skin assessment. So the pressure ulcer policy states that a skin inspection should be carried out or discussed with the patient at least weekly. So it's writing in this box any discussion or any skin inspection that has been carried out. Just remember to be looking at all the patient's pressure areas and not just documenting one particular pressure area. If you were unable to assess other pressure areas but you had a discussion about it, make sure that's written in there, and obviously writing that you've had a conversation with a carer in a residential home, for example, to state that all the patient's pressure areas are intact. This needs to be documented at least weekly. We then come on to the Braden assessment. So looking at each stage of this, the sensory perception box gives you these options. From a sensory perception point of view, this is really acknowledging whether the patient is able to know if they were sitting in a certain place and felt pain and discomfort, do they have the ability to then acknowledge that and reposition themselves based on knowing that. So you then choose from your options of how aware the patient is to know that they are in pain if they were sitting in one position for a long period of time. From a moisture perspective, are there any areas to the patient that are moist? So it's looking at incontinence and linking that to that it may be having a detrimental effect on wound healing. So thinking about your patients that might need a continence assessment, if it's a deteriorating pressure ulcer to a sacrum and the patient's always incontinent, you would document constantly moist, but on the incontinence tab, we then need to be saying that we're doing something about that, whether that's a continence assessment or seeking further advice, catheterization. So then looking at the activity of that patient. So what is the patient able to do? It's also worth just looking at what is the patient. So you may find the patient in bed, but having that conversation, can the patient get up? Do the carers get them up daily to try and be able to make a thorough assessment in relation to this? The patient's mobility. So is the patient able to move around freely, or do they need to be moved in that situation? Nutrition. So this would obviously link with your must. So I would link this to what general diet is the patient having. So this may be the amount of intake, but this can also be about whether the patient is having a poor diet. So if they were eating a high fat, low protein diet, that is going to have a detrimental effect on wound healing. So it's just acknowledging that within the Braden assessment. And friction and shear is a very important one. So looking at your patient and saying, is there already a problem? So if that patient has got a wound to their sacrum, thinking about in this assessment, does that patient have a risk that shear may be having an impact? Is the patient using a banana board and sliding across it and getting into their wheelchair, and now they've got wounds to their sacrum or ischium? Have they got Parkinson's? So do they constantly shuffle their feet in the bed? That may be a problem in general, even though it may not be, they may not have wounds at the moment. Is that a potential problem? And then just acknowledging this in other parts of your assessment. So on the surface and keep moving page, you can refer back to this to just try and link that element of shear and whether any other things could be put in, like a slide sheet to prevent that, or referral to OT, obviously, if it's a transfer problem. This will then auto generate your Braden score at the bottom, and then this gives you a guide of whether the patient is high risk, medium risk, or low risk. If the patient has a Braden of 16 or less, it is deemed that they do have some element of risk. So this is when there'd need to be a discussion within the notes about what we've put in to prevent anything. You would obviously do this on the first visit, and a Braden assessment and a skin inspection should then be carried out at least weekly on the patient, or more frequently if the patient's condition is obviously deteriorating, that they may need reassessment sooner. So the next tab is looking at surface. So this is really the equipment page. So the first box is looking at what equipment does the patient require? What equipment do they have in place? Have you acknowledged that actually this patient does need an upgrade in equipment? So you've discussed that and you're going to order it today. And the ordering form is attached just below here. So you've got a link to be able to order that. Just make sure in that box that you're also documenting whether the patient has refused any equipment. So if the patient, going back to your capacity page, has capacity, they have the right to refuse equipment. However, we need to document that in our assessment, we feel they would have benefited from it from a risk assessment perspective. However, the patient has declined but fully understands the risks. Then looking at any advice you've given the patient. So the patient may have a cushion but chooses to sit on a different chair. It's having that advice. It may be that when you've talked about equipment, the patient says they'll think about it. It's writing in there, when will that reassessment be given? When will that discussion be had again about with the patient about their equipment and their risks? It may be advice in relation to friction and shear, so linking back to what we just talked about. If that patient, you feel that there is a risk of shear, having that discussion of ways that they could move themselves or using a slide sheet to prevent the risk could be documented in there to show we've acknowledged that and tried to obviously prevent that risk of friction or shear to the patient. It may also be about if a patient has got their feet on the end of a bed and they're at risk of damage, you've had that conversation with carers, with relatives, or with the patient to make sure that their feet are always cleared of the end of the bed. That could also go in there. So the keep moving page is really about your turning advice and offloading advice that's been given to that patient. So the assessment of needs would be in relation to how often is that patient currently moving? Can they move themselves? Do they need support to move? And what do you feel would be relevant for their offloading, turning, or even just standing advice. So if the patient is sitting in their dining room for a prolonged period of time in their own home, you've assessed that actually they could be at higher risk because they're sitting on a hard chair. So you would then write that in there and then document it in the patient given advice box what advice you've given. So it may be that you've advised the carers that actually this patient needs to turn in 4 to 6 hourly. It is also worth bearing in mind that this needs to be based on what's going on with that patient. If a patient is end of life, it may not be relevant to turn them 4 hourly, definitely not at night. And it's having that discussion on an individual basis with the carers, with the patient, with, if possible, with looking at the people that are involved in that patient's care as to what is appropriate for that patient. Patients in relation to 2 hourly, 4 hourly, 6 hourly turning do not fit into little boxes. So always make sure that you're carrying out these assessments on a patient by patient perspective. The incontinence tab then just looks at that the patient's been reviewed. So does that patient have moisture associated skin damage? If you've identified moisture associated skin damage, all of the patient's assessment from their wound perspective can be documented on here. So as long as you've done the other elements of SCIM, you can then write about their moisture damage in this box. So you'd write in here that you've reviewed the patient, why you feel that it's moisture damage. So writing in there that actually it was butterflied on both sides, there is evidence of moisture damage, and the patient is incontinent. You'd write your reasons in there for that review of that patient and why you feel that was the case. And then in here, you'd obviously do your skin assessment to say that you've assessed this area of skin and this is what you found. You would also be writing in here what care plan you might have put in place. So whether that's following the moisture damage pathway at whatever element this patient is at, you would then put that in there, and obviously using your body map to identify where that moisture damage is. All moisture associated skin damage does needs to be Datex. So in there we've got an informing of incident box just to say that the Datex has been raised and a link to the Datex. Patients who have got incontinence related moisture damage should always refer to the continence nurse via task for advice. So there's just a tick box there just so that you can say that you've sent that task to the continence nurse to assess, as the patient does have moisture associated skin damage. This does include new damage, but also if the patient has been using pads, hasn't had an assessment for some period of time, and now has new or deteriorating damage, that patient should also be referred to the continence nurse. And there's just a box in there to say when we've discharged the patient, because obviously if you've done this first assessment, you've put the care plan in place, you've given the patient advice, you've raised the Datex, and you've referred to the continence team, and obviously completed all elements of your SCIM, so ordered any equipment, given any turning advice, then it is relevant for the patient to be discharged if this damage is not severe. So there's just a box on there to say that the patient has been discharged. Next tab is looking at nutrition. So you've got your must assessment in there. So you would put in the patient's height and weight. You can put this in meters and kilograms, or in feet and inches and stone, and it will convert this for you. If you just put 5'6", it will convert it into meters, and 10 stone 2, it will again convert that into kilograms and then calculate your must. If you're unable to weigh the patient, another option is by using the arm circumference. So taking a measurement between the patient's elbow and their shoulder. So take the measurement from the elbow to the shoulder and putting it in this box for the length, and then using the mid part of that measurement and taking the circumference of the patient's arm. So that will then give you a generalized idea of the patient's BMI. It doesn't auto generate this. However, you would then be able to track if their measurements are reducing, then you know that that patient is losing weight if they're losing quite a high amount on their arm. So down here, you would then take the BMI measurement that's been calculated. So there we've got 22.93. So we can see that that puts the patient in the 20 to 30 box. You'd ask the patient, have they had unexpected weight loss in the last 3 to 6 months? So saying to that patient, have you not been on a diet but lost weight? So you then talk to them about what they'd lost, and you'd put in, have they had any weight loss? If they haven't, you put NA. And acute disease effect. So this is really if the patient is acutely ill and hasn't eaten anything for more than 5 days. This isn't just if the patient has got acute disease, there needs to have been no nutritional intake for more than 5 days if you're putting them as a score of that. So that's how you'd complete that. This then goes into the scoring risk and tells you what to do. So if the patient was low risk, you'd repeat the screening. as per the policy. If the patient is medium risk, that patient should be observed more frequently, so a MUST should be done at least weekly, just to make sure that if it's one, that patient's diet isn't reducing and their weight isn't reducing weekly. If it's a 2 or higher, the patient is high risk, so they do need a referral to the dietitian, which could be found in the communication box on the left to send that referral to the dietitian, and you'd write on there that the patient had a MUST of 2, therefore would benefit from dietitian input. You've then got a box there to tick when that patient's been referred to dietitian if appropriate. If the patient is scoring a MUST of a low risk or a medium risk, then there is advice that can be given. So if that patient needs advice about fortifying their diet, so encouraging them, if they're saying to you, whatever I try, I can't gain weight, fortifying their food with high fat milk and butters, cheeses, things like this, you may suggest just put any of that advice in there. If the patient is already being seen by their dietitian, you can write that in there, and that they're taking any build-up drinks, 40-sip, Calagen shots, anything like that. This is where all your information can go that's in relation to that patient's diet. Okay, the next tab doesn't need to be used by yourself, so that's the tissue viability page. This is where we'll document, if we do a virtual review, what care plan we've suggested and any follow-up and who the follow-up will be by, so that will just be documented in there. Then we're breaking down into the individual wound assessments. So the next 5 tabs are the same, they mirror each other. So you've got a pressure ulcer 1 and a pressure ulcer 2, and then you've got pressure ulcer 1 and PU1, sorry, and then you've got pressure ulcer 2 and PU2. So we'll just go through pressure ulcer 1, which looks at what category of pressure damage you found. So you just tick the box that is relevant. This does still say grade because System 1 hasn't changed it at the moment. We should be using the terminology of categories. So you would just tick whichever one is appropriate and then use the pencil to write where that was. So if you write in there category 2 wound found to left hip, it just helps to specify exactly what wound on this tab we're talking about. Then you'd use your body map. So these tabs will only be used for one wound at a time, which just makes documentation identification of the wound easier. So there should only ever be, so you'd use your red pressure ulcer button, and there should only ever be across these tabs 1 dot per tab. So we'll put it on the patient's left hip there, make it red. Put it on the patient's left hip, and that will identify what we're talking about. There's then a link to the Datex. If you found a category 2 wound or above on moist damage, it does need to be Datex, and then you'd write in there that that Datex was submitted. There's also just a prompt to say that photography of the wound has been taken, because obviously for every pressure ulcer, wound photography should be taken, because this allows TVN to confirm the Datex. Also in here, duty of candor can be reported, so that you've had that discussion with the patient that they've got a pressure ulcer, and it will be investigated, and should they want to know the results of this, then they can. Obviously, if the patient doesn't have capacity, this duty of candor needs to be met with the appropriate person and reported in System 1 and on the Datex. So the next page is referring to the same wound, but just goes through what does that wound look like and what is it presenting as. So you just record here again which wound you're talking about, so we know exactly in the tab journal. You then look at the tissue type, so you'd be ticking a box and saying the wound had 30% slough. It's just important when you're recording these, particularly slough, to say that that was 30% after cleansing. So we know that you've assessed that wound, you've cleansed it, and then you've looked at your percentages of what tissues within the wound, and then we'd write 70% granulation. So this should always add up to 100. You've then got your wound measurements. So wound measurements should be taken at least weekly, particularly when wounds start to deteriorate. It's a really important factor to look at what has that wound trajectory been doing in relation to wound healing. So writing your wound measurements in weekly is really important. There's then a box to write whether there was wound odor present. We then go down to exudate. So there are presets here. So there's cirrus, so your straw coloured exudate, whether there was blood stained, whether there was thick green and yellow exudate, or whether there was a mix, whether there was no exudate at all. It then goes into what levels of exudate there are and what consistency is. So just remember, by pressing the control button, you can select multiple elements of this. So exudate could be cirrus, it could be, there won't be no X-date if it's serous. So it's serous, it is moderate, and it has a thin consistency. So you can select all 3 of them and press OK, and all 3 of them will go in there. If you did then need to write anything extra, you can still free text in that box. So looking at the skin assessment, this is more to do with what is going on around the area of that wound. So is it healthy skin? Is the skin macerated? Just remembering that if you've got wounds that have got high levels of maceration, actual damage, that does also need to be acknowledged and datex and something put in place, like a barrier spray if it was a leg ulcer, for example, or a pressure ulcer, to try and stop that exudate from damaging the skin. Another important one in pressure ulcers on this is whether the surrounding skin was blanching or non-blanching. So this is your evidence, if you're writing about a pressure ulcer, to write that on that assessment the surrounding skin was non-blanching, or if it's a moisture damage, to write that the skin is blanching. Okay. The next tab is about wound infection. So this just gives you prompts to remind you of what the signs of wound infection is. Just remembering that one of these signs on their own does not mean the patient has an infection. You need to be looking at your whole patient. So if we were looking and a patient had increased pain, purulent discharge, and an increased smell, you may think that there may be an infection present. On smell, just make sure that you are completely cleaning that wound and discarding the old dressings and what you've cleaned the wound is, and putting them in your dressing bag away from the wound before you're using that as an assessment technique, because general wounds will have a smell. They've got dead bacteria in there, they've got dead fibrogen cells, they will have a smell, but it's after cleaning is when that smell assessment should be done to gather whether the wound has an infection or not, and then linking this with your other signs. Just remembering, if you do query an infection, that we do need to be screening the patient for sepsis, as obviously they could be at higher risk. There's then an assessment of pain, so putting in there what pain the patient reports. When you put that assessment in, you are then able to use the pencil to write what type of pain it is, how frequently the patient gets it, what pain relief they're taking, so you can just put a little bit more information in there. So then it's looking at, based on what you're going to dress this wound with, what is your aims and goals of your treatment? So this is about this specific wound. Have you said that that wound is sloughy? So your aim and goal for that particular wound is going to be to de-slough the wound, and you'll link that to what you're writing about what you're going to dress the wound with. So this box of aim or goal is specifically about the wound you're talking about. Okay, so then you would write in this bottom box what you've decided to dress the wound with, how often it needs to be changed. Just remembering that you do still need to complete this in the care plan. However, whatever you write in there, so you could write wound to be dressed twice weekly with Iodaflex and Comfeel. You can then copy that and put that into your care plan. So that is that page, that's your assessment. So each time that you assess that wound, it should be these 2 tabs that are being completed, just to say where the pressure ulcer is, and then obviously your assessment of the wound bed. So the following tabs then just repeat until we get to lower limb assessment. So this is for when you're doing an assessment of that limb. So this would involve a Doppler, but it's also about, if you're going out for the first time to see a wound, it is relevant to start to do some of these assessments, and this can be our unqualified staff as well as our qualified. So there's a lot of information on this first leg ulcer assessment box. What I've done is put in a lot of the signs that you may see both in the patient, so in their past medical history, what the patient presents with, and then also what the wound looks like, that can then give you some guidance to start thinking whether that wound is caused by arterial disease, venous disease, or whether it could be a mix of the two, which will obviously have an effect on our care plan moving forward. So again, you can use your control button, bottom left, to choose multiple things about that patient's past medical history, about whether they've been known to the vascular team, whether they're telling you they've got numbness in their feet, whether they get an intermittent claudication, and whether they get pain when they put their legs up. So pressing OK would then put all of these into that box, and you can see there this patient has a high number of arterial signs. So these would be patients that you would be concerned that they do have some sort of arterial involvement, and it is then escalating that to an RN if you're an unqualified member of staff, because they may need a referral to the vascular team if not known to them, and they will need urgent further assessment from an RN. But this can start to gather your information about what is going on with that patient and what is causing that wound to be non-healing. So the next box just goes into what leg edema the patient's got. So when we're talking about a positive stemmer sign, this is about whether you can pinch on the patient's webbing between their second and third toe, whether you can pinch an element of skin and can pick that skin up or not. Where you can pinch the skin up, the patient has no stemmer signs. If you can't pinch that skin because the foot is so swollen, then the patient has a positive stemmer sign. So the inability to pinch the skin between the second and third toe would give you a positive stemmer sign, and this is an indication of extensive edema. You can write in there if the patient is already known to being treated for chronic edema or if they're being treated for lymphedema, and put that in. So consultation just allows you to write anything else about that first lower limb assessment. So what the patient's telling you that may have not been included above, and then any advice you've given the patient. So is that patient sleeping in their chair at night? They've got swollen, wet, leaking legs. You're giving them advice to elevate their legs to try and resolve this. You could put that in there. If it's advice that you got there and the patient already had hosiery in place, but they haven't been wearing this, it could be advice you've given them in relation to that. It's also patient given advice should also be about our education to that patient, so that you've said to that patient that their wound may be non-healing because of arterial or venous disease, and that we'll be doing an assessment to determine that, and that it may mean that they need compression, bandaging or hosiery, and they may need to wear this for a long period of time. It's always important putting that in that first assessment and discussing that with your patient in that first assessment. So your Doppler will link into this first lower limb assessment. So on there, you've just got where your patient was laying. It then gives you the opportunity to put in all of your ABPI measurements for each side. I've also put in there the ankle circumference. This is really important when then monitoring if that edema is reducing, when that patient needs to be measured for hosiery. You've got your ankle circumference there to look at. And this should also be used and repeated on further assessment. So the patient's ankle circumference should be reassessed, ideally at least fortnightly, to see if it is reducing. And it also allows for that to be recorded on the patient's record for when hosiery needs to be ordered. You've got all that already there. So you've got right ankle and calf and left ankle and calf. So you've then got the outcome of your Doppler. So it may be that you've Doppler completed, what the ABPI was, linking that to that patient's risk factors. So, okay, their ABPI was in range, however you're concerned because they've got a past medical history of heart failure and other concerns. So you're either seeking further advice from a specialist nurse, or you're putting them in reduced compression and keeping them under close supervision. You just write any of your outcome in there to be able to do that. So your leg ulcer page then looks at exactly the same as the pressure ulcer one. What does that wound present as? So all of these are very similar until you get down to the hosiery. There's just a box there to write what hosiery you've assessed the patient for or what you've put on. So you can select that and put that in, or you can free text in there any discussion you've had with the patient about hosiery, when hosiery's been ordered, just to make sure that that's being monitored, and just remembering that that patient can be in hosiery while they've got an active wound, as long as the leg isn't swollen and there isn't a lot of exudate, then the patient can be in hosiery from early on in their treatment. Then you've just got your body map that obviously allows you to identify where that patient's leg ulcer is, and then that repeats up to 3 leg ulcers. Then you've got other wounds. So this just allows you to document any other wounds that the patient may have. So it may be a surgical wound, it may be an extensive hematoma, it may be a laceration. And I put wound of skin in there because it could be anything else. So you can just tick the box and write exactly what that wound was. For surgical wounds, it is important to write what date did that patient have their surgery, what date are their clips due to be removed, so that's documented. And then obviously your assessment would be the same as explained for the other wounds. There then is a nursing assessment tab there, which just allows nurses to write any communication, any notes that they wanted to write that doesn't fit in anywhere else in the template. So any telephone conversations you may have had with any other MDT, a consultation, so what has happened with that patient that you just want to write some extra notes, that's why that's on there. There is then just referrals forward so that you can evidence that you have referred this patient onwards. So doing a referral to the vascular team and writing why that has been done. So linking that to your Doppler assessment, to the fact the patient had monophasic pulses, just writing that you've referred that patient and that is logged in there. Then there is just a case manager box, which is really for the management of patients. So this is really where you would fill in if you had a caseload review. You could write in there, the patient has been reviewed and this is what was discussed at the caseload review. It's a really good way to be able to monitor what's going on with your patients. And then EQ5D Q50, which is obviously needs to be done when the patient is admitted and discharged from the service. So you would go down and ask the patient these questions. This audio, the visual analog scale asks the patient to describe on a scale of 0 to 100 how do they feel about their health, with 0 being their worst health and 100 being their best health. So you just document in there that number. And the level of patient activation is more linked to therapies. So community nursing wouldn't overly use that, but you would fill in the CQ50 and the visual analog scale when the patient is admitted to the service and when they are discharged. And that is a template. So just as an overview, what you're really looking to do is always be thinking about your ESSKIN. So I've put this on there to spell out ESSKIN so it reminds you. So always when you're assessing a patient, be thinking about them factors and documenting conversations that you've had, because a lot of the time we do these things, but it's not documented. So looking at their skin, looking at their equipment that you've given advice, whether they've got any incontinence problems that may be attributing to damage, and their nutrition. And then doing this first assessment, so your past medical history and your medications, ensuring you do that on first assessment, and then reviewing that. If that wound is non-healing, looking back at what medication that patient is on and what is their past medical history, and documenting that you've reviewed that as the patient is non-healing. So that's what you do really on a first assessment. You'd look at your ESSKIN. Really, each assessment we should be acknowledging ESSKIN, and then for whatever wounds you are assessing, you'd use these tabs, whichever one's relevant, to write what you have seen on that patient's wound, and obviously writing about where the wound is and any datexes that you've submitted. Okay, so hopefully that gave you a bit more insight into the wound care template. Obviously, if you have any questions about it, then just speak to your manager or the tissue viability team. We'll always be happy to give advice. It is just about documenting all the conversations that we have and ensuring that that is relevant within the patient's record. But just come to us if you need any further advice at all. I hope this was helpful.